Hello everyone, I am Dr. Rajesh Swarnakar, National Secretary, Indian Chest Society. Would like to give you a warm welcome on behalf of ICS. We are embarking on a path-breaking educational training course on non-invasive ventilation. This webinar-based course would be 5-series webinar with national and international faculty. The objective of Essentials of Non-Invasive Ventilator course is to further education and NIV in a simplified case-based pedagogy. In every webinar, we will touch upon case studies and have panel discussion to provide broader perspective of clinical therapy. I would strongly encourage you to take and attend all the 5 webinars and complete the assessment at the end of each session. I would like to thank ResMed India as industry partner for coming forward to collaborate with ICS for Essentials of Non-Invasive Ventilation, the online course. Coming to today's webinar, we have our well-known Dr. Raja Dhar, Director, Department of Pulmonology, Fortis Hospital, Kolkata, as the moderator. We are pleased to have Dr. Nirja Shastri, who is a respiratory physiologist and PFT expert, currently working as professor and head of the Department of Physiology at KMMCH Medical College, UP. She would be speaking on lung physiology in NIV perspective to have the ball rolling. We are also pleased to have Dr. Milind Sovani, Assistant Professor, Consultant Respiratory Physician and Lead Clinician for Acute NIV and Domiciliary Ventilation at Nottingham University Hospital of the NHS Trust. He would be speaking on NIV basics. I wish all the success for this online course, and I hand over to Dr. Raja Dhar for moderating this opening webinar. Thank you.
Good evening, everybody. First of all, I would like to thank Indian Chest Society and the ResMed team for having me here and to talk about on the physiological part of today's topic, that is non-invasive ventilation. So I start my PPT. Just something which I would want to say before the outset is that it may not be possible for me to cover every physiological aspect of NIV in 15 to 20 minutes. I've tried to simplify and cover the important ones, but that doesn't mean the rest of all don't matter. The flow of my slides would be something overview of the respiratory failure. What are the normal mechanics of respiration which are relevant to NIV, and how do you apply those concepts when you're dealing with application of NIV? So respiratory failure, we all know, we can divide it into one because of lung failure and another type of respiratory failure, which is because of pump failure. So anything outside the lungs would amount to pump failure, and it could be anything starting from the higher centers to thoracic cage, to the muscle, to the neuromuscular failure, spinal nerves. Anything which is outside the lung causes pump failure. So respiratory, if you talk about lung failure is because of majorly 3 causes. Out of that, ventilation perfusion mismatch is the commonest one. Then you have development of shunts and impaired diffusion, hypoventilation, and alveolar hypoventilation. So I'm going to discuss the 3, at least 3, which are the important ones: VP mismatch, shunts, and impaired diffusion. And this lung failure or respiratory failure develops, which is called as hypoxemic respiratory failure, which is type 1, where PCO2 may be normal or may be decreased. Other side, which is the pump failure is nothing but it is an imbalance between the higher centers, your thoracic cage, and your respiratory muscle load and capacity. This develops type 2 respiratory failure, which is hypoxia definitely is there, but with hypercapnia, we call it as hypercapnic respiratory failure. So ultimately, whether it is lung which is causing the failure or whether it's a pump which is causing the respiratory failure, the brunt is borne by the muscles, and that causes. So it is not that if there's a lung failure, so pump failure is not there. I mean hypoxia, so hypercapnia cannot be there. They are interrelated. Now coming to treatment of this respiratory failure, what is failing in respiration is ventilation. So we are going to provide ventilation to treat it. Now this ventilation could be a negative pressure ventilation, which is like how it happens physiologically, or it can be a positive pressure ventilation. Negative pressure ventilation, we call it as non-invasive, but non-invasive can be positive pressure ventilation also. So we have two positive pressure ventilation, which can be invasive or which can be non-invasive. So NIV or non-invasive ventilation is something, is the technique where we are providing the ventilation, but without using any invasive artificial airways, like, you're not doing tracheostomy, you're not doing intubation. So that is why it is non-invasive. Now it can be used. So negative pressure, I'm not talking about because this is not done nowadays. Very common is the one we use with positive pressure. So I'm going to talk about the presentation is going to be on non-invasive, invasive, positive pressure ventilation. Now there are two types of pressures which we are using. One is you're providing pressure throughout the respiratory cycle, which is called as CPAP, constant positive airway pressure. It's positive. Another one is, it is bi-level positive air pressure. That is, during inspiration, the pressure is different, and during expiration, the pressure is different. And this is called IPAP and EPAP. Remember that EPAP is same as CPAP, or also called as PEEP. We'll see what is it. Now coming to mechanics of respiration, if mechanics would be so easy, taking the air in and breathing it out, I think my job would have been very easy, especially now. But it is not just breathing in and breathing out. A lot goes beyond these two, breathing in and breathing out. If you look at this, how the respiratory cycle starts, that when the inspiration happens, before that, if you look at this, during inspiration, your inspiratory muscles, they contract, especially diaphragm and external intercostal muscle. And when they contract, the volume in the chest wall increases. Whereas during expiration, the volume is decreased. So why do you want to bring this change in volume? Because this change in volume brings change in pressure. So this is your normal when no air is flowing. So here your pressure inside the lungs and pressure outside, or atmospheric pressure, they are equal. But what happens during inspiration, the air has to flow in, your contraction of the muscle increases intrathoracic volume. And as Boyle's law, volume and pressure are inverse. So increases, the pressure in the thoracic cavity goes down. And so there is decrease in the pleural pressure. Now pleura is outside, covering the lungs. Pressure in the, decreased pleural pressure will also bring down the pressure in the alveoli. It will also come down. And this, now the alveolar pressure becomes subatmospheric, lesser than the atmospheric pressure. And this is how the air flows from high atmospheric pressure to low atmospheric pressure. You can see this is how, this is your alveolar pressure, and the lower one is your pleural pressure. Alveolar pressure, say it's from 0, it becomes negative during inspiration. When this becomes negative, the air flows in. So there's a volume change. And during expiration, it becomes positive and air flows out. Similarly, your pleural pressure, which is anyways at resting also is negative, it becomes more negative during inspiration and becomes slightly towards positive. It doesn't become positive minded. And this is how the normal pressure volume changes happen. Now see what happens in NIV. This is normal where there is no positive pressure ventilation is done. And here, this is a slide with the CPAP. CPAP is continuous positive airway pressure. Here, you're continuously, whether it is inspiration or whether it is expiration, you have positive pressure. So here, so this is your pressure, okay, which is continuously, which is always there. Okay, so here patient is inspiring, patient is expiring, but the pressure is there. And this is also known as positive end expiratory pressure. This is what happens in BiPAP. I told you there are two types of pressure. One is different pressure, one different IPAP and EPAP. So this is your IPAP and this is your EPAP. The difference between IPAP and P gives you pressure support. Now when this pressure rises, you see the flow happens. When the flow starts declining, the pressure starts declining. And this is how inspiration, expiration happens. That was our pressure and volume. Now another thing which is important in mechanics is gas exchange in the lungs. It is just not the ventilation, the air which is coming in the lungs. It has to get, the oxygen has to get exchanged at the alveolar capillary membrane. Oxygen has to go to the pulmonary blood and carbon dioxide has to come to the lungs or to get expired out. So that you have ventilation, that is the air coming in the lung or the alveoli, and then you have perfusion. And when this combination is optimum, adequate ventilation, adequate perfusion, nothing more, nothing less, that causes adequate gas exchange. So we need to focus on ventilation and perfusion if we want a good gas exchange. So talking about alveolar ventilation, before alveolar ventilation is the air in the alveoli. And we know alveoli take part in gaseous exchange. This is a respiratory zone which they exchange air. But how the air comes in, right? So first is the minute ventilation. That how much air can come into the lungs and out of that, how much takes part in the gaseous exchange. So total what you're getting is your minute ventilation, which is almost around 6 liters. And out of that, 4 liter is the one which is taking part in the gaseous exchange. So if in your NIV, if you can add pressure and the flow to the mask, you can, and if your dead space is not more than normal, or you can let that air go into the alveoli, and that is called alveolar ventilation. Now we have air in the alveoli, but you need blood to carry this oxygen further and get carbon dioxide in the alveoli in exchange. So this ratio of alveolar ventilation to the alveolar blood flow is called as ventilation perfusion ratio, and it is almost 0.8 to 0.9. And at this ratio, we say there's an optimal gas exchange. That is the maximum oxygenation takes place at this ratio. So you need this ratio. Now what happens when this ratio is disturbed? This ratio can be disturbed if you have more dead space. One is, we know there's an anatomical dead space which is fixed 150 ml. But in conditions where this dead space is increased, okay, sometimes the air travels up to the alveoli, but there's no blood to carry that oxygen further. So that becomes a wasted ventilation. Okay, so this shows that we need to have both your ventilation as well as perfusion for gas exchange to take place. Talk about low VQ ratio. Low VQ ratio means your ventilation is reduced, but your perfusion is normal. Now this low ventilation perfusion ratio, what it causes is whatever air is present in the alveoli, it is very less for the blood to carry it further. Now what will happen? The blood will go or will shunt and gets mixed with deoxygenated blood. So there's a mixing of deoxygenated blood because it doesn't get oxygen. It goes and gets mixed with the oxygenated blood. And to compensate for this, physiologically, any underventilated alveoli, the vessels around it, they undergo vasoconstriction so that this is not wasted. But again, if this mixing is too much, if deoxygenated blood like right to left shunts, so if this mixing is taking place and imagine there is no ventilation at all, so which is that absolute shunt. But here, low VQ ratio, yes, there is a ventilation, but it is less, but it is not at par with the perfusion. So patient develops shunts. And these are the patients who can be treated with the oxygen because the problem is with the ventilation. Then imagine opposite thing where you have high ventilation ratio. That means your ventilation is way too much than your perfusion. So your perfusion is less. Now what will happen? Whatever air is present in the alveoli, it is there, but it cannot be taken further because there's no blood to carry it. What will happen? Because of this now, this ventilation goes, it becomes a wasted ventilation, or we say the anatomical, or it goes into an anatomical dead space. So it's of no use. So you see whether it is a low or whether it is a high ratio, there's a problem with the gas exchange, and that hampers your gas exchange, and that obviously increases the work of breathing. And this can happen in a number of diseases. And these, if you look at these are also the indications for using an IV. Then there's a shunt. So difference between low VQ ratio and shunt is to be understood. I told you low VQ ratio can be treated with oxygen. They respond well to oxygen, but shunt means absolutely zero ventilation. So that means all the blood, it gets shunted. And these are the people who do not respond to the oxygen. So that was a VQ ratio. Now what happens? Where is this VQ? Do we have in all parts of lung, do we have this good VQ ratio? No. Physiologically also, there's a heterogenic heterogeneity between this VQ matching. So if you talk about the apex of the lung, they are over, the alveolar pressure is more there, so they are over distended. And go to the basis, there is the ventilation is less, but the perfusion is more. So again, there is the apex of the lung, you have wasted ventilation, and in zone 3 you have shunted, more of shunts. Where is exactly physiologically also this VQ matching is happening? This is happening at zone 2. I'll talk about what is zone 2. Here to understand that, if you look at this, you see on x-axis you have pressure and on y-axis you have lung volume. So on x-axis you have transmural pressure, that's the pressure required to inflate the lung volume and the chest wall. So the solid line is for both lungs and the chest wall. Okay. When the lungs are expanded, they expand, but lungs have elastic, our respiratory system is full of elastic tissue. So what is elastic tissue? It's like a rubber band. You stretch it, it tries to come back at its resting position. Similarly, when the lungs are expanded, they also recoil. They also recoil to the resting position at the end of the inspiration. Similarly, chest wall also does that. But the point to remember is that this recoil tendency of the lungs and the chest wall is not in the same direction. lungs trying to recoil in the inward direction, and chest wall tends to recoil in the outward direction. So like they are two opposite things. And this opposite direction movement, or at the end of the inspiration, is the one which creates that negative intrapleural pressure. Now VQ matching, so this is for lung compliance. If you see this orange dotted line, this is showing that lungs try to recoil in the inward direction and your chest goes into the opposite direction. So where these forces balance each other, that volume of the lung is called as functional residual capacity. It is the amount of the air which remains in the lung after normal expiration. So you need FRC. At this volume, you will have adequate VQ matching. That means adequate gas exchange. If you talk about hypoxia and hypercapnia, like both the types of respiratory failure, you will see here that amount of pressure, amount of force which you require to inflate a lung at what I require to inflate a lung, which is at FRC, is this pressure. For example, if you look at this is the FRC and I require this much pressure here. But if I have to inflate a lung which is totally collapsed, for example, in hypoxia, it is totally collapsed, I need more pressure. Okay, so that means the muscles have to work harder. The work of breathing is increased. Okay, the pressure has to be more, and in overdistension or hyperinflation or COPD patient or hypercapnia patient, again the pressure required is way too. So the optimum pressure which works to bring this optimal volume where the VQ matching is there is good gas exchange, that is FRC, and which is seen in zone 2. Now, why it is important? Why I'm talking it here? Because NIV increases functional residual capacity. When it increases the functional residual capacity, all these your forces become equal. The lung expands at a volume which is not exposed to a lot of resistance. Okay, how do you apply all these concepts? Now we know the respiratory failure, you have lack of oxygen, you have more carbon dioxide, more is the carbon dioxide, your pH causes acidosis, and because of all that, ultimately, mumbo jumbo, the work of breathing is increased. So what do you want? We want to improve oxygenation, we want to improve ventilation, that is carbon dioxide get out. That will improve acidosis, and we also want to decrease the work of breathing. How? So there are different ways by which NIV does. So if you need oxygen, you will have to open those closed or underventilated alveoli. You have to increase the lung volume, because when alveoli are expanded, obviously the FRC will increase. You will have to increase, I'll talk about compliance, you have to increase the compliance, you have to increase the minute ventilation so that alveolar ventilation increases and the rest, your oxygenation and these things follow, decrease the work of breathing. So patient has to, the inspiratory muscles have to work a lot, but they cannot cope up because there's too much of load being put on that. So we need to unload. We need to unload that load, and that is what NIV does. NIV unloads those respiratory muscles. And all this ultimately increases or improves. There's a symptomatic improvement in patient status. So to understand the effect of NIV, ultimately the three things. We need adequate gas exchange, we need decreased work of breathing, and symptom relief. These are the major, again, I'm not kind of excluding the other effects, but to understand, to simplify it, this is how I could do. Now, first is your gas exchange. How do you do that? You need good ventilation, okay, and perfusion. So first of all, you have to increase the ventilation. How will you increase the ventilation? You have to increase the tidal volume. And when this is increased, you can see the effects. The ventilation, the minute ventilation translates into alveolar ventilation. And you see this when this is your alveolar ventilation, the gray shaded part. Now when alveolar ventilation is increased, see what happens. This is the gray, this part, this is your alveolar oxygen. Obviously, the alveolar oxygen is increased, your alveolar, this is going to get increased. But what happens with the increase in the minute ventilation, you have decreased arterial carbon dioxide. Decreased arterial carbon dioxide will also cause decreased alveolar carbon dioxide. Okay? Because the carbon dioxide is decreased now, the pH will also be increased. And your saturation of oxygen, as the ventilation or the minute ventilation, this increases, the saturation also increases. But as we know that up to 60, I mean, when you're at 70 partial pressure of oxygen, it is almost, hemoglobin is almost saturated, 98%. It is almost saturated with oxygen. So that is why it is showing plateau, that even if you increase, the hemoglobin is already saturated. So this is why you see a plateau. But increased ventilation will cause oxygenation, will cause removal of carbon dioxide, and will correct patient's pH. Now, alveolar ventilation, this you see, so underventilated alveoli, where the air is not reaching or because there is an obstruction, you need to ventilate those alveoli. And this is how the recruitment of, or we call it alveolar recruitment. When the alveoli, the closed, the collapsed alveoli are recruited, are opened up, what will happen? Again, the oxygenation, you have increased tidal volume, ventilation, you improve the VQ match, increased functional residual capacity, decreased shunts, and decreased diffusion distance. And pulmonary vascular or pulmonary vasoconstriction in response to hypoxia is also decreased. Now, is it that the alveoli once recruited will again collapse back in the next cycle? No. Because we have CPAP, which is continuous positive airway pressure, the pressure is provided continuously. So this prevents the collapse of the alveoli. So if you see this, if PEEP is here 4, and even if it goes to 10, it goes to 12, the alveoli they're not collapsing, they're recruited. Airway pressure increases, the recruitment increases. And what is
time check?
What is?
There is 5 minutes more.
And what is this PEEP is doing? Again, it is good VQ matching. It prevents if there's no PEEP, the alveoli will be close, open, close, and this will cause the injury to or it can cause lung injuries. That is prevented. It also increases the lung compliance, that the distension of the lung, and it also helps in the more is the volume, less is the airway resistance. And diffusion, as I told you, increased surface area, you have capillary distension, again the good VQ match. Now coming to what are the factors affecting on the respiratory system when patient is on NIV. So either the force which is the muscles have to produce, and the one which is the pressure which is to be provided by the machine. Now these two forces, they have to act on the respiratory system for what? They need to produce a pressure which will counter the elastic force and the resistance, because the elastic, more the lung is expanded, it is going to bounce back, and when it bounces back, it has a pressure, and that pressure will try to expel the air out. So you need that means the collapse of the lung. So you need a pressure to keep it open. Okay. So elastance and the resistance are the two major the forces against which the pressure has to act. We can call it as compliances. So what are the resistance one has to face when the air flows in the lungs? One is your compliance. More if you expand, but if there are more elastic fibers, the compliance will not happen. Compliance and elastance are in two opposite direction. Tissue resistance and airway resistance. Tissue resistance doesn't hamper much. So this is your resistance of the airway, which will try to decrease the airflow, and this is elastness. That means more is the elasticity in the lungs, like in your interstitial lung diseases, the lung will try to collapse. And compliance is the opposite. Less is the elastic, more is the expansion. So overall, if you look at these, the pressure which has to be produced or which has to be produced either by the muscle or by the machine, depending on whether it's assisted ventilation or it is unassisted ventilation, it has to counter these two forces. Sometimes in hyperinflation or COPD patient, what happens? You have too much of air inside, and too much of air means the lungs are hyperinflated, and they also have a lot of elastic recoil pressure. And for muscles to start a new cycle of respiration, the pressure has to go down subatmospheric. But this pressure doesn't let it, if there's no assisted ventilation, this pressure stays, and that is called as PEEP, intrinsic positive end expiratory pressure. And your CPAP or your continuous positive airway pressure helps to counter that pressure. So it is kind of, that's how it unloads the muscle, respiratory muscle work. Told I'm running out of time. So work of breathing, if you look at the muscles now coming to how the muscles act, you have the whole respiratory system has CNS drive. Then you have a respiratory, this center in the brainstem or in the medulla, it gets inputs from your chemoreceptors, peripheral or central, stretch receptors, mechanoreceptors. This is also acted by higher centers, and your pain and emotional stimuli, they also act on this. Now, respiratory balance, this CNS drive depends upon the capacity and the load applied to the muscles. Normally, this capacity and the balance and the applied load is optimum, that is normal, and that causes adequate gas exchange and no air trapping. But when this load is increased in many diseases, this is how the muscle gets fatigued and the muscle load increases and the failure occurs. So for muscles, normally should generate sufficient force to overcome and sustain both your elastic and resistive load for adequate gas exchange. And there are many causes which can cause muscle fatigue. And ultimately what we see is hyperventilation, decrease oxygen and increase carbon dioxide. And this is where your NIV comes into the function. It decreases the patient's effort. Okay, number of efforts. Okay, so it may be totally dependent on the ventilator to do those efforts for the patient, and also decreases the muscle load for given tidal volume, and that reduces the fatigue. It shows that, you know, with NIPV, if you see the work of breathing goes on decreasing, and this is how the muscles are unloaded. So different mechanisms how this happens. This is just to show. If you see this is your pressure and this is your volume. And the diagonal line is for compliance, how much lungs can expand. This is normal, A is normal. B is the area the left to this compliance line is the work between the ventilator or the machine and the patient is a problem. So you see this. So properly applied, after finishing, properly applied, synchronous, assisted, properly applied, and it has to be synchronous because desynchrony again produces problem. Should be there to reduce muscle loading and increase the muscle recovery. So this is how overall your NIV will help. it improves the pH, it increases the oxygenation, muscle unloading. So ultimately, all these inputs, if you see, they are going to the brain center, to the respiratory center. And if you can modify these inputs, obviously your central drive will also be as per the inputs, or would be better. Upper airway, your CPAP kind of stents it, keeps the airway open. It also has roles on cardiovascular system because it decreases the load on the heart. That's why it is used in cardiogenic pulmonary edema. And this is how, I'm sorry, I had to rush because I'm running out of time.
So Neerja, the last slide, we need to get on. So we'll
this is the last slide.
Presentation. Yeah, please.
So this is the summary how your NIV acts based on different physiological parameters. So that is the take-home message, that you have to see what kind of patient, what kind of pathology you are dealing, and according to that you are applied what kind of NIV. And as compared to mechanical ventilation, obviously NIV, when indicated, has fewer complications. And that's all I have to present. Thank you very much.
Thank you, Dr. Neerja, for introduction and handing over the presentation to me. Good evening, folks. I'm Milind Sovni, one of the respiratory physicians based in Nottingham. And as mentioned earlier, non-invasive ventilation is both my passion and my expertise. I would like to thank ICS and ResMed both for giving me the opportunity to do this talk. Today we will be talking briefly about historical overview, basics of ventilation, principles and indications of non-invasive ventilation, how to set up an IV, and troubleshooting of common problems. So Paracelsus first used mechanical ventilation by Bellows in 1530, and then Dalyell developed a negative pressure tank ventilator in 1838, and subsequently Emerson in middle of 1950 developed positive pressure ventilation. So the negative pressure ventilation, as we all know, is called iron lung, which was first used in Boston in Children's Hospital, but during the polio epidemic it was used extensively. As you can see on the right side of my screen, at the bottom right hand corner, you've got patient lying in the tank ventilator, whereas the head is sticking out, and as the pressure in the tank would be turned negative, patient would suck air in, and when the pressure is turned positive, patient would breathe out. In 1950s, positive pressure ventilation was devised, and as we know, this is now the norm, the standard of mechanical ventilation, both invasive and non-invasive. So we'll briefly talk about respiratory failure. This might be a little bit basic, so apologies. So respiratory failure is divided into two types. Type 1, where you have got hypoxemia but no hypercapnia. Common mechanism is VQ mismatch, and it could be due to pneumonia, PE, lung contusion, interstitial lung disease, and so on. Type 2 respiratory failure, you have got both hypoxemia and hypercapnia, and it could be due to reduced drive, muscle fatigue or weakness, and increased dead space. And what we have to remember is that in COPD, you have got both muscle fatigue and increased dead space weakness, whereas other conditions such as drugs, you would have reduced drive, or motor neuron disease, for example, where you would have muscle weakness. So schematic approach to respiratory mechanics. So it can be divided into electrics, pump, and membrane. Electrics are your brainstem and phrenic nerve. Pump is the muscle pump, with diaphragm being the biggest and the strongest and most important respiratory or inspiratory muscle. And membrane is the alveolar membrane. So electrics provide the drive, pump moves air in and out, and is the membrane where gas exchange happens. Here, I would like to stress that deep, slow breathing is efficient than rapid, shallow breathing. Why do we say this? Let us take two patients, both with minute ventilation of 6 liters. One patient is doing respiratory rate of 10 and tidal volume of 600. So with tidal volume of 600 and dead space of 150 mL, with each breath they are doing 450 mL of alveolar ventilation, and in a minute 4.5 liters of alveolar ventilation. Another person doing 6 liters of minute ventilation but with respiratory rate of 30. So each tidal volume is 200 mL. Dead space wouldn't change, it would still be 150 mL. So alveolar ventilation is just 50 mL per breath, so really ineffective. Therefore, total alveolar ventilation per minute is 1.5 liters. So you can see that deep, slow breathing is efficient breathing, and our aim when we provide NIV is going to be to move from an unstable state of rapid, shallow breathing to a more stable state of deep and stable breathing. The other thing I wanted to highlight is that if you look at arterial blood gas, particularly blood gas that is done on air, and this is important, it has to be done on air, and sum of PaCO2 and PaO2, if it is more than 125 millimeters, boys breathing room air, then that would suggest that lungs are okay. For example, your PO2 is 70 and CO2 is 65, that would give the sum to be 135 millimeters. Now, if that is happening, then it's unlikely that they would have interstitial lung disease or COPD or something. It is more likely to be drugs or neuromuscular condition which is causing reduced drive or reduced ventilation. Right, so this brings us to goals of non-invasive ventilation. Why do we want to do non-invasive ventilation? First and foremost, relief of symptoms. Secondly, it reduces work of breathing. And as we do those things, we improve patient comfort and optimize and stabilize gas exchange. Once we have done that, patient starts to synchronize better with ventilator, that is the non-invasive ventilator. Thereby, we can avoid intubation and reduce mortality. And we often see that when we start patient on non-invasive ventilation, a reduction in respiratory rate and patient settling down nicely, sometimes actually falling asleep on NIV, is often a very good sign that we have got it right. Here are two diagrams actually. On the top left-hand corner where I'm showing with my arrow here, you can see the normal breathing, which goes from 0 to negative. So negative during inspiration and 0 pressure during expiration. This is CPAP here. And again, you can see that interestingly during CPAP, as the patient breathes in, there is a small inflection of pressure. But basically during exhalation, the pressure is positive. So it stops alveolar collapse. And then we have got the bi-level ventilation. So on the bigger screen here, I've got bi-level ventilation. So you can see in bi-level ventilations, we have got two components, IPAP or inspiratory positive airway pressure, which is set at 20 in this instance, or rather 18, and EPAP, which is set at 7 in this case. And we can see at the bottom here, the settings. So you've got two types of pressures, the inspiratory pressure and the expiratory pressure. So setting up of an IV. So the important components of an IV are machine, circuit, and mask. But before we talk about non-invasive ventilation, just wanted to highlight the invasive ventilation. Often invasive ventilation, at the bottom right corner of my screen, you can see somebody being invasively ventilated and that they have two limbs in the circuit. One limb is inspiratory limb at the bottom and expiratory limb at the top. Now in non-invasive ventilation circuits, often you have just got one limb, and therefore it is really important that we have got an exhalation port either in the circuit itself or in the mask. Very, very important. And why? Because it is through this exhalation port that all the gases that are exhaled by patient are going to be washed out, so that there is no CO2 buildup in the circuit. So how does non-invasive ventilation lead to improvement in respiratory failure? So as we see, there are two components, EPAP and IPAP. Let us look at individual components. EPAP, what does it do? It offsets intrinsic peak, particularly in patients with COPD. They will often have intrinsic peak because of gas transfer. So EPAP will offset that, and that will help patient to initiate the next breath. It reduces FRC and improves oxygenation. It ensures CO2 washout from the circuit. So EPAP means expiratory positive airway pressure. To give that, there has to be fresh gas flow through the circuit during exhalation, and that helps wash out of CO2 through the exhalation port. In addition to these, particularly in obese patients and patients with unstable upper airway, providing EPAP makes sure that you have got a patent upper airway. So that was EPAP. Now what about IPAP? Now IPAP is the pressure, the inspiratory pressure that pumps air in and inflates the lung. This is the pressure that decides how big your breath is going to be, and if you get it right, you actually will improve alveolar ventilation. And as we know, better the alveolar ventilation, better the CO2 clearance. So IPAP will help you with CO2 clearance, whereas EPAP predominantly will help with stenting airways open and could potentially help with oxygenation. What about modes of ventilation? So we are going to just look at some basic things here. So let us look at two basic types, and we'll briefly mention the third. So it is controlled mode and support. So control means the user is the doctor who sets all the parameters. So it can either be pressure controlled, where you will decide how high the pressure is, or volume control, where you will decide how much volume the machine pumps in. Now, all modern ventilators, the non-invasive ventilators, are pressure controlled ventilators. Occasionally you will get a volume controlled mode, but by and large, for all practical purposes, when we say controlled, it will mean pressure controlled ventilation. And in pressure controlled mode, you decide what is the IPAP, what is the EPAP, and how long the patient breathes. Now, how do you decide how long the patient breathes? It is called time cycling. So you would say, for example, let us say 1.2 seconds of inspiratory time. So the pressure would go up, pressure would stay there for 1.2 seconds, and then drop down to level of EPAP. Pressure support mode, how does it differ? In pressure support mode, patient actually initiates the breath, patient decides how long the inspiration is going to be, and what you decide is how much support you will give when the patient initiates the breath. And then there are other modes such as AVAPs, IVAPs, and servo, so where there is, you can set both volume and pressure support. But for the timing, we will leave that alone. Here are a couple of examples. So on the left hand side of your screen, you've got pressure support ventilation. On the right hand of your screen, you've got pressure control ventilation. You can see here at the initiation of each breath, there is a small, very, very small turquoise notch. I'm showing my arrow there. And what that means is that's where patient has tried to breathe in. When patient tries to breathe in, what happens is as patient creates negative pressure, the flow reduces, and it is the flow sensor that is used in most of the ventilators these days. So the machine senses change in flow or a drop in flow and pumps the inspiratory pressure. Now, once patient has breathed in, what happens is we can see the flow here. Once patient peak inspiratory flow, or patient's inspiratory flow reaches about somewhere between 75 and 25% of the peak value, the machine then cycles into exhalation mode as set by the operator. And you can see here, this is inspiration and this is exhalation, and you can see during exhalation, it's going all the way back to baseline. So we can show that, we can demonstrate that there is no there is no airflow obstruction and gas trapping. On the right hand of the screen, you've got pressure controlled mode, and you can see the flow pattern is much more squarer. It's machine which is deciding what is the inspiratory pressure, how fast the patient will breathe, and Not only just that, but also in addition to that, it will also decide when the machine will go into exhalation. So this is controlled ventilation, and in both cases we can see, that we have managed to get the ventilation really perfect. Now, before we go any further, I just wanted to highlight something. So this is an Australian study where they looked at 400 patients, and in Australia, patients have to travel a long distance to reach hospital. They randomize patient to either controlled oxygen or not controlled oxygen during their journey to hospital. And what they demonstrated is that particularly in patients with COPD, controlled titrated oxygen significantly reduced the risk of death by 58%. So it's really important that although we talk about NIV, even before we think of NIV, use of controlled oxygen, particularly in COPD, is important. So what are the indications of non-invasive ventilation? Here we are going to stick to the acute presentations. So we know acute exacerbation of COPD. So you've got hypercapnia with respiratory acidosis. It's really important to remember that for COPD, for acute exacerbation, you have to have high CO2, so CO2 more than 6.5, and respiratory acidosis, which means the bicarb has to be more than 25 and pH has to be less than 7.35. There are other cases such as decompensated hypercapnic respiratory failure in obesity hypoventilation, or scoliosis, or neuromuscular problems such as motor neuron disease. And in these conditions, irrespective of pH, once patient is hypercapnic, they need non-invasive ventilatory support. Cardiogenic pulmonary edema is another one where mostly CPAP is enough, but NIV can be considered if patient is hypercapnic. So this is, I personally find this chart very helpful. We had devised this as part of the BTS NIV guidelines. You've got the indications, contraindications, all details of setup. And I would highly recommend you look at this slide after the talk, because it gives step-by-step guide in terms of how to look at whether somebody needs NIV or not, what are the contraindications, what pressures to use, and how to monitor. So we'll take an example here. So we have got somebody who is acutely unwell. So the question is, does this patient need non-invasive ventilation? So they are being given 28% oxygen, pH is 7.36, PaO2 is more than 100 millimeter, and PaCO2 is 60.7 millimeters of mercury. And as we can see, their bicarb is 31 and saturation is of 97%. So do they need non-invasive ventilation? I'll let you think for a couple of seconds. So that will depend, whether they need non-invasive ventilation will depend on what is their background condition. So we know that, as shown in this slide with arrows, we have got normal pH, but high carbon dioxide level. Now, first thing we have to do is titrate the oxygen, particularly if they are COPD, then optimizing treatment because they are not acidotic. So optimizing medical management, giving controlled oxygen, giving nebulizers and steroids, so on, will be really important. But if that doesn't stabilize and they continue to deteriorate and become acidotic, then we have to institute an IV. On the other hand, if they have got scoliosis or obesity or neuromuscular problem, then we don't have to wait for respiratory acidosis. We can commence them on non-invasive ventilation. So how do we set up non-invasive ventilation? The single most important thing here is choose the right mask. If you get your mask correct, in most cases, you will succeed in non-invasive ventilation. Just one thing to remember today. Please spend time in getting the mask right for your patient. Second thing, safety. Ensure there is an exhalation port, as we discussed earlier. You can start with EPAP of 4, IPAP of 8, and then gradually build your IPAP up as patient gets used to it, to a level where you can see that patient's chest is rising nicely, that there is enough tidal volume and reduced work of breathing. And then of course you have to check ABG, respiratory rate, heart rate, blood pressure, etc. at 1 hour, 4 hour, 12 hours, and then daily, or as often as needed. So here, just like to mention COVID pandemic. During COVID pandemic, we have done something slightly different in that we have used a non-vented mask and a vented circuit. So you can see in the diagram, everything is labeled. So this is the purple exhalation port. As we can see, it's through this exhalation port, the CO2 is going to be washed out. But what we do have is a viral filter. The reason we want viral filter during COVID pandemic is that anything that is coming out will be filtered through this viral filter, so that we make sure that whatever we do is safe for us and our staff. So really important message. Now we will come to looking at some of the common problems. So common problems sort of are asynchrony. What is asynchrony? Asynchrony means there is no harmony between the machine and the patient. They are out of sync. So when the patient tries to breathe out, machine tries to breathe in, and vice versa, and that will just be ineffective. So what are the various types? You can have unsupported inspiratory effort, you can have double triggering, auto triggering, and various other things. We'll just look at the first couple. So you've got here, the arrows are showing your breaths by patients that are not supported by ventilator. And the commonest reason for this is because there is mask leak. So the machine doesn't realize when the patient is trying to breathe in, or patient is too weak, or the trigger is not sensitive enough. But the commonest problem is mask leak. So again, get your mask leak sorted. Double triggering and auto triggering. So auto triggering means, so here we can see the first breath is patient has triggered the breath and machine has supported. On the second effort, you don't see this patient trigger, this little notch. So why does this happen? It can be again because of leak. If there is suddenly high leak, machine will think patient has tried to breathe in and pump, and machine will pump air in. Or if there is condensation in the circuit, then it can move back and forth, mimicking patient breath effort, or if the trigger is too sensitive. But again, the commonest problem here would be mask leak. I think I'm going to skip over the other types of asynchronies, but I've left it in the presentation. So if you are interested, you can refer to it. So just let us focus a little bit about how we get it right. So I've got an example here. So we can look at the screen. So on the left hand side, we can see that a patient is in pressure control setting. You can see we are trying to set everything, but what patient is doing all the work himself because the setting is not right. You can see patient trigger 100%. This means patient is completely overriding whatever we have set up. And you can see as a result, there, when patient is trying to breathe in, the machine sometimes is not supporting. And more importantly, you just aren't getting enough volume into patient's chest. So this is ineffective ventilation really. Now, when we move that into ST mode, because we can see that this is not really working, patient is trying to work a bit faster. So we have roughly kept the pressures the same, but we have changed the ST mode. And what we have done is we have given slightly longer breathing time. So inspiratory time here is 1.1 second on the left hand side in the pressure control mode, whereas it is 1.2 second in the ST mode on the right hand side. So it's supporting patient's breath a bit longer should the need be. However, what seems to have happened importantly is that with patient allowed to drive the ventilator and set the pace himself, the pattern is much better. Second example, we can see that patient here is again being ventilated in controlled mode, and the reason we know that is the breaths are orange. So when patient is being given breaths, tidal volume is around 390 mL on the left hand side of the screen, whereas on the right hand side of the screen we have made a couple of changes. We have increased the IPAP to 21, which was 18 on the left hand side screen, and that was because we were not getting enough tidal volume. This is a big individual who needs bigger volume because we were unable to clear his CO2. So what we have managed to do is improve or double his tidal volume from 394 to 794, so basically from 400 to 800 mL roughly. We have almost doubled his minute ventilation, and again you can see really nice coordinated synchronized breathing. Now the only thing that I want to highlight here, slightly more technical, but I would still do, is when you look at the flow pattern, this is inspiration and then it cycles into exhalation mode. You can see it coming nicely, but this blue line doesn't quite go all the way back to baseline. So what's happening is as we are pumping more in and giving bigger breaths, it's leading to a little bit of gas trapping. So unless we eventually sort this issue, when patient comes off ventilator, he will really struggle to breathe by himself. So after a while, what we can do is either drop the IPAP a little bit or reduce the inspiratory time to give a bit longer time for patient to breathe out. These were some examples. So I would like to conclude by saying that we have got some take-home messages. So non-invasive ventilation is for hypercapnic respiratory failure. Please remember that, not for hypoxemic. Second thing is when you are setting up your ventilator, you ensure that your circuit and mask combination has exhalation port. Whatever combination you use, you can either have exhalation port in the mask or in the circuit, but there has to be an exhalation port. Mask fit is the single most factor which will decide the success of an IV. And then we have to remember it is the IPAP which helps CO2 clearance and EPAP which helps with oxygenation as well as with CO2 washout from the circuit. Please spend some time with your patient and look at them clinically. It's an intervention. You don't just set something and walk away. You stand next to the patient, you spend 15 minutes, half an hour, see how they're responding. It's a dynamic process. It's a two-way process. So stand there, look at your patient, see how they respond, make appropriate changes, and that's the best recipe for an IV success. Many thanks.
Hi, good evening, friends. My name is Dr. Rajadhar. I head the Department of Pulmonology at Fortis in Kolkata. You've just heard two wonderful talks from Dr. Nirja Shastri about the physiology of non-invasive ventilation. And then you've heard about non-invasive ventilation, the basics, from Dr. Milind Sovani. We'll go into our panel discussion where we will discuss some of our questions, some of your questions, and we'll go around the panel and we'll try and answer some of the questions that you've put to us. So before we did that, there's a couple of things that I wanted to announce. I think Dr. Swarnakar, the Secretary of the Indian Chest Society, has said this already, but just for the sake of reiteration, this is the first of an entire module on non-invasive ventilation that's been developed by the Indian Chest Society. We hope that you would attend each of these modules. There was a question in the question box which said, why do Indian Chest Society meetings don't stick to time? And why do we not finish on time? So I'm sorry we have been late by about 5 minutes, but we'll try never to do that again. I understand that your time is precious, but I hope you can spend the extra 5 minutes for a meeting which is hopefully of good academic value. There'll be some poll questions at the end of this, where we will try and ask you some questions based on the talks that you've heard today. And there'll be a same pattern in each of the modules that we do over the next few days. And at the completion, we'll give you an Indian Chest Society certificate of participation and completion on non-invasive ventilation. For the meeting, let me have the pleasure of introducing a good friend, an expert on non-invasive ventilation. Vijay, can we see you? So Dr. Vijay Hadda. Dr. Vijay Hadda is Associate Professor, Pulmonary Critical Care and Sleep Medicine, All India Institute of Medical Sciences. The busiest hub at the moment as far as COVID is concerned, and the best institute in the country for pulmonology and for lots of other specialties. So Vijay, welcome. We'll start off with you.
Good evening, everyone.
Hi Vijay, hi. I haven't managed to see you till now, Vijay. Maybe the video will come on in a minute. I'll start off with you, Vijay, just to get you into the discussion. There's a question which talks about patient selection for non-invasive ventilation and the caveats. So Milind has covered this already, but from your perspective, if you could talk briefly about what you think about when you're selecting for a patient for non-invasive ventilation versus invasive mechanical ventilation on one side and just maybe oxygen therapy on the other, and what are the caveats that you would tell people about, people who are starting off their intensive care units? So give us your thoughts, Vijay.
A very interesting question, and especially those who are starting their practice in critical care and they want to start NIV usage in their ICUs. I think this is the most important, crucial question. First, we should know that what are the candidates where we can use NIV. And then I think most of the thing has been already covered by Dr. Milind, but we can reiterate that there are few conditions where NIV usage is very, very successful and supported by high level of evidence. There are lots of studies, including good randomized controlled trials. And these conditions, if we talk about in acute care setting, then a COPD exacerbation is the number one. Then cardiogenic pulmonary edema is number two. Then other conditions where it is commonly used, although the evidence may not be very strong, include the hypoxemic respiratory failure in immunocompromised patients. And then there are more which have already covered by Dr. Milind Swane. The most important thing I think which we should consider whenever we want to start NIV is we should clearly know that where NIV should not be used. That means we should know the contraindications. And the contraindications are clearly patient-centered. If we see that patient angiorrhea is not good enough, and if patient is hemodynamically unstable, or patient is having imminent arrest, or the patient is too sick, I think if these kind of patient you come across, then straightway there is no for NIV. Similarly, if we see acute hypoxemic respiratory failure, there is little bit confusion. If Dr. Rajadhar is using NIV, or maybe I am using NIV, then we can probably try in even severe cases of hypoxemic respiratory failure. But if somebody is a beginner, then I would suggest that whenever there is a PF ratio is less than 150, or let us say 200, then we should not go for NIV. Better, we should straightway opt for standard intubation and so on. So I think if these can be kept in mind, then I think life will be a little bit easier, especially for beginners. And then I think I have covered most of the things, but there are a few other contraindications also, like if somebody is having upper GI bleed, or there is chances of aspiration, and sometimes we say that if patient is having copious secretions, respiratory secretions, although that is not an absolute contraindication, and but if somebody have observed that patient is having lots of secretions and he or she will not be able to handle those secretions, that is also a point where we should give a thoughtful point before going for NIV.
So very important points, Vijay. Can I just pursue on that secretion part? You know, often you and I face challenges with people getting plugged, poor cough reflex, elderly individual. You don't want to put them on invasive mechanical ventilation, but you find that keeping them on NIV long term actually gets them to have atelectasis more at the bases. They cannot cough out. Their removal of secretions become a challenge. So how do you circumvent all that? How do you manage secretion in these patients?
Very interesting question, sir. Actually, if we see till now, there is no guideline in the world which can guide us that how we should use a NIV if somebody is having loads of secretions. But we, in collaborations of international researchers, we have just wrote a guideline how to handle these secretions when we are giving NIV. So I came across the literature that even if you use NIV, it helps in secretion clearance also. But the issue is if you are saying that there is lots of secretions, especially in an acute care setting, then it's a big no. But in chronic setting, if the patient is having secretions and which are not very copious one, again we can use NIV. And in many patients, although the literature is not very much, but there are case series and few case reports which have suggested that NIV itself can be used for airway secretion management. So I think that's maybe taken as a relative kind of thing. It should not be absolute contraindication that somebody is having a maybe copious secretion kind of airway disease or maybe bronchiectasis which have some kind of secretions that should not be devoid of NIV if it is indicated.
Sure.
And if we talk about acute care setting, so we published our experience, I think 2 years back, and the patient who admitted with bronchiectasis. So we found that none of the patients we required to discontinue NIV because of copious secretions. So this much confidence we have in NIV
Sure.
if it is used in a expert hands or maybe little bit experienced hand. So to finish this, in nutshell, we can say that in acute care setting, especially the copious secretion, especially when the secretions are not very much, then NIV can be used. And in chronic setting also the same applies.
Thanks a lot. So to all the panelists, if there is anything that you want to add, just raise your hand and I'll come to you. So we want this to be a discussion rather than being just one panelist talking. So please do raise your hands if there's anything that you want to say. Yeah, so Milind, I'll come to you. So there's a question for you. You can put your comment about the secretions first and then I'll answer my question. There's a couple of people who've asked about use of trigger sensitivity, which you've mentioned, about cycle sensitivity, and how you adjust these in routine practice and how useful they are in the management of patients with non-invasive ventilation. So your comment about secretions first and then the answer to this question, Milind.
Raja, and hello everybody. So talking about secretions, in most cases of COPD, secretions is not such a big issue. By and large, with good physio, we can get secretion clearance. The problem really comes either in bronchiectasis or more so in patients either severely frail or in patients with neuromuscular issues. There is a lot of echo, Raja. Can I?
So we cannot hear a lot of echo, but what I'll do is I'll put mine on.
Okay, that has helped. So we often use cough assist devices with secretion for secretion clearance, as you know. And what these devices do is provide positive pressure, let us say, of 40 centimeters for good a second or two, and then we breath stack so that 3 cycles of big breaths followed by a negative pressure of 60 centimeters. So these are significantly higher pressures. But what it allows us to do is to get the secretions up into the upper airway from which it can be suctioned out. So that's comment about.
Yeah, unmute yourself, sir.
Hello.
Dr. Raja, your mic is muted.
Very sorry, Milind. So what I was saying is very appropriate comment about the cuff assist. So I think we underuse it in a lot of setups in our country. I mean, I'm sure Vijay uses it a lot in the All India Institute, but there's a lot of centers in India throughout the country where there's a lot of NIV use without the use of a lot of cuff assist, and that's a valid point. The other question I asked you was about trigger sensitivity and cycle sensitivity and how it's useful in operating non-invasive ventilation in a standard setup. So we're not going sort of hi-fi, standard setup, general physician, intensivist using it. What are your comments about these? You mentioned something, but if you can repeat it again for us, please.
So in most cases, the machines these days are really good. Certainly the machines, for example, the machines that ResMed and other companies produce will have standard trigger settings which will be adequate in most cases. Cases where you may need to look at adjusting these trigger settings is particularly patients who are very frail or very, very severe COPD, or particularly neuromuscular patients who are so weak that they can't even trigger. But in that case, it is better to completely take over the ventilation and give controlled ventilation, because it's possible that patients may fall asleep, and during that time, particularly in REM sleep, they just wouldn't be able to trigger. So it's really important that if somebody is really frail, struggling to trigger, or not triggering because they are obtended or have got diaphragmatic weakness, then we really have to provide them controlled ventilation, particularly for overnight, so that you don't find that in the morning the patient has failed to trigger and has died.
Right.
The other situation where you might have to change the trigger setting is if there is a significant double triggering going on. But again, the common problem often is mask leak. So first thing, always, I would say in all NIV questions, first principle is go back to mask and sort the mask. So that's the trigger. The second issue is flow cycling or inspiratory time. So there are two things in this. What we need to look at is, particularly this is important for COPD patients. So what we want to do is set the TI, which is the rise time, how quickly pressurization happens. That needs to be sort of either very fast or second to that, so that the pressure builds up quickly. And then often, if you are giving ST mode, then once the inspiratory flow comes down to about 75 to 50% of peak flow, machine will cycle into exhalation mode. The idea is that you keep the inspiration short and give longer time for exhalation so that patient can breathe out and there is no gas trapping at the end. Reverse of that, patients with obesity, it is important that you give them enough inspiratory time. So typically for COPD patient, inspiratory time would range from 0.9 to 1.1 second. So, and again, this is only when they are falling asleep. Whereas for obesity hypoventilation patient without airflow obstruction, inspiratory time of 1.3 seconds, 1.4 seconds, and people with neuromuscular issues, because they have completely normal set of lungs, 1.4 to 1.5, occasionally longer, but that's the kind of inspiratory time. That would ensure, particularly the longer inspiratory time would ensure adequate inflation of bases for obese patients.
Thanks, Milind. Thanks. So I'll try and quickly run through some questions. There's plenty of questions. So I know I'm asking questions which are detailed. So the answers will take long, but if it can be as concise as possible, I'll get Neerja into the discussion. Neerja, I'm sorry, the questions are clinical. So, and you're very detailed in the describing the physiology, but let me try and get your opinion first. So you've talked about offloading the respiratory muscles and increasing the capacity of respiratory muscles with non-invasive ventilation. I've got a couple of people who've asked about the model of weaning, the modes and precautions. So I'll actually go to Vijay with the clinical part, but I wanted to ask you, like you talked about offloading the respiratory muscles and increasing capacity with NIV, when you're weaning people off, is that physiological a challenge when you're trying to increase the work of the respiratory muscles again? How much physiologically is that a challenge for people?
So when you are weaning, everything goes opposite what was happening before. So suddenly from unloading, it is a loading. So your work of breathing will increase because because positive pressure will go into a negative intrathoracic pressure, more air would enter, tidal volume would be increased. Your load on heart also increases. So everything which was happening earlier when patient was on NIV gets reversed. So it is definitely a challenge. So that is why de-escalate. It cannot be done abruptly. You have to do weaning at particular hours in a day, and that should be done. So if you're de-escalating, it cannot be abrupt.
Correct. So great answer, Nija. Thank you. So on the same note, Vijay, if you have to de-escalate slowly, tell our viewers how you go about doing that in a standard manner. So there's obviously variations, but give us some sort of an outline of a protocol that we can follow, Vijay, in trying to de-escalate patients, as Nija calls it, from non-invasive ventilation when we are weaning off.
So once we have realized or we have noted that patient has recovered from the acute illness for which the patient required NIV. So it is typically happens at least after 24 hours of start of NIV. So after first 24 hours, we should reassess whether patient has improved or not improved. And if we think that patient, the respiratory status has improved, clinical status has improved, overall ABG is acceptable, like that. So once we have assured or once we have satisfied that this patient has recovered from acute illness, then theoretically saying there are three ways of weaning, because we are giving the pressure support. So one way is, as Dr. Nirja was saying, we should not abruptly remove the NIV. So easiest is just remove the NIV and then see. Then as Dr. Nirja said, that it may not be very physiological one. I will discuss it later. The second thing is, we can gradually decrease the pressure support. Let us say the patient is having pressure support of 10 after 24 hours, and we are planning that patient can be weaned now. So we can gradually decrease the pressure support. Let us say around 2 to 4 every 2 to 4 hourly. That can be done, and patient can be monitored closely. If he is tolerating that pressure, let us say after 2 hours we repeated the ABG, and at that point of time pressure was 8. You can subsequently reduce by 2. The second way is you can reduce the time of ventilator. Like if we are giving 24 hours, then instead of 24 hours, we can particularly divide the whole day in three shifts, and in one shift NIV, one shift off, like that. Let us say 4 hours of NIV, 4 hours off, then 4 hours NIV, 4 hours off, like that. So there are three ways of doing this. So I think the most of studies, they show that this off and on NIV, that is the most commonly followed protocol. And second one is gradually reduces the pressure support. These two are commonly used. No one is doing abrupt removal of NIV. Although if we see the literature, I think there is no study which have compared this except what we have done and published, I think last year. And we found that there was no significant difference, especially if we talk about NIV failure or weaning failure. So that was not there. So there is some data to suggest that we can do abrupt removal also. But the caveat in this study was that was very, very small study that can be taken only as a pilot study to give a thought that this kind of approach can be done, and these results should be confirmed with a bigger kind of trial. So till that trial is there, the best way is either you reduce the pressure or you reduce the duration of NIV usage. I think I hope I have cleared the situation. Sir, your mic is again mute.
So very clear. Thank you, Vijay. And I'm sorry, I keep putting my mic on mute. So very clear. I know Milind has a short comment on weaning, and then I've got a question for you, but I'll come to the question once you've done your comment on weaning, Milind.
Thank you. So, as Dr. Haddad said, that there is a multi-center study which specifically looked at this question precisely in COPD patients, and what they showed is stopping an IV after 3 days as opposed to continuing for a week, there was no difference in any of the outcomes. And the reason for that is that once the airflow obstruction, the basic mechanism where your diaphragm is at a complete disadvantage, where there is a lot of shunt, once that has been reversed, then the patients are able to take it off. About 3% of patients might need longer term support, but that's a separate question. Second thing about weaning is going to be a small proportion of patients with obesity hypoventilation might end up requiring an ongoing support, particularly nocturnal support, because without that, if we take that away, then they are just going to revert back into hypercapnic respiratory failure.
Sure. So just to sort of pursue, this was not a question I was intending to ask, but just in response to what you've just said, Milind, the fact that, so you said that stopping NIV at one go versus doing a staggered stopping the way Vijay described it was more or less equal in patients with COPDs. Was my understanding correct, or did I?
Yes, but that is correct, provided you have treated and corrected the acidosis, hypercapnia, and most of the bronchospasm. Importantly, the reason COPD patients go in respiratory failure is that they are so hyperinflated that their diaphragm at a complete disadvantage. It just cannot contract any further. It's completely pushed down. So once that is helpful, they can then take on the work of breathing. And just I wanted to add one thing. I agree with Dr. Hatta, is that sometimes what you see is patients being treated, particularly COPD patients with an IV, doing well. As soon as you take them off an IV, they become very breathless. And the reason for that is we have overventilated them and caused gas trapping. So in that case, just over half an hour reducing the pressure support and increasing the expiratory time will often allow them to overcome the gas trapping, and they can then get on with breathing much better. And ResMed have got that facility, and I'm hoping that other producers will also do that. The down ramp, where it allows that gas trapping to be sorted, rather.
So as a carry home message, Milind, so there's lots of people who, like we said, are starting off with non-invasive ventilation, don't use it that often. I think the approach that Vijay was talking about, where you actually wean people off rather than cutting it off, because exactly when the penny drops, when the diaphragmatic flattening goes away, when the bronchospasm goes away, is something which is very difficult to actually sort of put your finger on. So maybe some period off, some period on, maybe overnight on, and then is a better plan compared to sort of stopping at one go.
Totally.
Totally. Right. The other important question, Milind, so I was going to ask you this question. I think this is important. Plenty, about 7 or 8 people have asked this question. You know, there's the pressure control mode in non-invasive ventilation. You're using the ventilators and using pressure support. So some people have asked, who do you choose? Some people have asked, how do you overcome the asynchrony when you put people on pressure control? Some people have asked about the use of dexmedetomidine in trying to get people to synchronize on pressure control. So if you can give us a brief answer, but put all of that into one capsule and give it.
So thankfully, most ventilators nowadays will have ST mode. And the beauty of that is what you do with ST mode is you set a floor. You set the floor so that you say, for example, you will set a backup rate of, for example, 15 and inspiratory time of 1.1, for example, say in COPD patients, and 1.3 in obesity hypoventilation patients, and a decent inspiratory pressure. Once you have done that, what ST mode then does is any breathing that patient does over and above that, patient will control the exhalation into or cycling into exhalation depending on patient's inspiratory flow. So using an ST mode for this, but giving enough but setting a good floor so that when patients fall asleep, because what happens is when you get ventilation right, patients have been struggling, they haven't had sleep for 3 days. First thing that happens is in a couple of hours, they fall asleep. And that's where, unless you have actually got the backup rate and the backup inspirator time set, they will again trip into respiratory failure and asynchrony. So I have found initially using ST mode is very helpful rather than pressure control, particularly in acute situation. Once they are out of that, so in neuromuscular cases or obesity, but usually once they are out of the acute phase, then control mode tends to work better because there is a set pattern of breathing.
And another common question, just to add, you've answered most of my questions, Bilin, about using a drug to get people to synchronize on pressure control ventilation. Do you think that's a strategy which would be recommended? Do you think that's actually dangerous, especially in patients who are in hypercapnic respiratory failure, using an agent like dexamethasone or fentanyl, for instance? Is that something you would recommend, cautiously recommend? Any comments?
I think one of the most important things, so occasionally you can have asynchrony with agitation, and agitation is very difficult to control. So we tend to use Oremov on the grounds that patient can only take it as much as, if they are totally flat, they are not going to take it, and they will take it again when they sort of wake up, and it does suppress a bit of breathing. But then what you also do is you take over their ventilation. However, it is important to be cautious, as you say, and probably use it very, very cautiously, particularly in patients for mechanical ventilation. If somebody is also for full escalation, then that sedation needs to be used either in ICU settings or under very close supervision with quicker access to intensive care facility. If you have got somebody with advanced COPD where only NIV is the goal, then we tend to be a little bit more liberal with sedation.
Sure.
And one last comment, sorry
Yes,
to
sure.
interrupt. Agitation is associated, as we all know, with poor, it's a marker of it's highly likely that your patient will fail. So I think we need to be aware that if your patient is agitated and for full ventilation, then have low threshold to escalate them to ICU.
Right. Grand. Thanks, Bilin. Vijay, I've got a question for you. Important one, I think. Everyone is asking it. So how do you avoid pressure source at the bridge of the nose and over the face with prolonged use of non-invasive ventilation? So people where you need to use it for prolonged hours, how do you go about preventing these pressure sources?
I think this is very important issue, especially among patients who require an IV on long-term basis. Even in ICU also, we have observed that on day 2, many patients will have a rash over the nasal bridge, if not anywhere else. So I think most of the time, these skin rash or ulcers happen because of the wrong setting of an IV, especially if mask is not appropriate size and there is lots of leakage. One thing. Second thing is, many times we tie the mask too tightly. We think that if you apply more pressure, then there will be less leakage and like that. So I think if we use appropriate method of tying or the strapping as described, that whenever you apply mask or face and then you see how tight it is, it should be really fit, but it should not be very tight. And the best way to see that is you insert your 2 fingers between strap and the scalp, and it should go easily. It should not require lots of force to insert your fingers. If we do that, I think most of things will be taken care of that. The second thing is, I think you do all the maneuvers to reduce the leakage. If there is more leak, then there are more chances of the pressure source. The second thing is, suppose somebody is requiring an IV for long-term basis. Let us take example of this OSA or maybe any other apnea syndromes. So in that case, one way may be, which I don't know how many of us are using, we can give 2 type of interfaces. which patient can interchange. Let us say one is full face mask which cover the full face, and one maybe which is oronasal. So the patient can intermittently use, maybe cycling off the interface. Let us say 1 month he can use full face mask which cover the full face, and 1 month he can use mask. So I think that is another way by which we can reduce the pressure source. And then there were few protective strap-ins are also available in market which can also be used, but I think practice is not very much for that. So as a beginner, or maybe most of us, what we are using is the correct pressure or pressure while tying up the straps and reducing the leakage. And second, we can advise the patient to have 2 kinds of face mask which can be used with cycling, one followed by the others.
So very interesting concept of cycling, Vijay. Can I just add to it? So with the COVID pandemic, there's a lot of centers in India. I know Milind uses it in the UK. Do you think the helmet mask actually circumvents this problem, or do you think it adds the same problem but now to the lower end of the neck and the shoulder rather than being on the bridge of the nose?
So I think if we talk about the pressure source of nasal bridge and this one, automatically there is no use of discussing that, because the pressure site is totally changed, and as you discussed, the site will be different. But as far as I have experienced, I have used only in few patients, so I have never come across any patient who is having sores or ulcer because of this. So maybe Dr. Milind have more experience in this. He can share his experience. But to me, I have never seen a patient who had pressure sore because of this.
So Milind, quickly, your experience with the helmet? You're on the mute, Milind.
Can you unmute yourself, Dr. Milind?
Yeah, sorry. So helmet is really good from pressure sore point of view, but because of the big dead space, triggering can be a problem. Similarly, you are likely to need much higher flows, and the ventilator needs to have much bigger pump to actually cope with that. So we just need to be sort of aware of what, one thing offsetting other. The other thing we can do is use just the oronasal mask. So you've got the nasal prongs that go in the nose and the mask sitting around the mouth. The benefit with that is it has got very low dead space, so triggering becomes a lot easier, and it does not cover any of the any nasal bridge at all. And then of course the total or a full face mask. And one thing that we tend to do is in the NIV chart, we also have got a check for nasal bridge pressure areas. So even if there is any suggestion that there is redness, then the option is that you apply a silicone chip under where the pressure area is, or change the interface.
Sure.
Prevention.
So, thanks, Milind. Sure. So I'm smiling because there's a question I find quite funny actually, but I'll ask it to you. The question is that what is your opinion about AVAPs? The 2 big competitors try to attract us to each other by providing AVAPs which are more suitable. What should people do? Short answer, please, Milind.
So there are very few patients. So we have got about 500 patients on home ventilation. Of those, we have just submitted for the ERS. There are about 15 patients or 20 patients on either AVAPs or IVAPs. So as you, if you want, I can go into the details either of A or IVAPs, or can just stick to the basic principle that basically you are trying to do volume assured pressure support. And the cases where you want either of these two, either AVAPs or IVAPs, is where, for example, somebody is requiring ventilation for a longer period, and where, for example, change in posture. So occasionally some people with significant obesity, with COPD, so change in posture suddenly means, or during change in sleep phase, suddenly what happens is what pressure was enough earlier is no more enough, and you actually need to give them more support. So, or patients who are neuromuscular, or indeed patients with spinal cord injury, where when they are sat up and ventilated during the day, they need different pressures, and when they are lying down, they need different pressures. But by and large, if you get your ventilator setting right, then in most cases, you don't need the IVAPs or AVAPs.
That's a very strong message. Thank you, Milind. So 2 last questions quickly. One to Nirja. Nirja, there's a question which talks about the hypoxic drive and maintaining saturations between 88 to 92% in the fear that patients can become hypercapnic. So the question is, by giving this degree of hypoxia, you actually increase the chance of mortality, or does the reduction of hypercapnia and respiratory acidosis reduce mortality in patients with COPD? So if you could give us a physiological answer, and then I'll go to Vijay. You're on mute, Nirja.
Okay. So this question especially comes in perspective of COPD patients, where we need to be very cautious how much oxygen are we giving, because COPD patients, they already have higher carbon dioxide, and their respiratory center or their the central drive is stimulated by hypoxia. So if you go on increasing the oxygen in these patients, they will lose on that stimulation of the central drive, and that could be actually detrimental for the patient. So we have to be very cautious in COPD patient about the oxygen.
Thanks, Nirja. Thank you very much. So last couple of questions for you. Quick answers, Vijay, please. One is, how much of leak can you actually tolerate? So the ventilator tells you there's 40% of leak. Should we be okay with that? Or would you be happier with a lower leak? What makes you decide what's okay and what's not okay, Vijay, in the acute scenario?
I think number is okay if ventilator is showing that the leak is 40%, 30% or 50%. Number is okay. But I think most important point here, it should be the patient. If patient is comfortable, you are able to achieve your physiological parameters. Like if I started patient on NIV, let us say IPAP of 14 and EPAP of 6, and patient of COPD, and after maybe 15 minutes, his respiratory rate has come down, he is looking more comfortable, then maybe I will not give much of importance to the leak at that point of time. Although we should try to keep it as minimum as possible, and probably up to 20-30% is acceptable one. It is not going to cause major effect, unless you have detected that this leak is causing lots of asynchrony, maybe premature triggering or double triggering kind of thing. If that is happening, then we should go back to see why this leak is there, and we can reduce by some means or other so that it can be reduced further. But to me, I think 20-30% is okay. And even if slightly more, and if patient is improving and comfortable, then I will not be bothered. But number are important. Like if suppose the ventilator machine is showing 60% leak, 70% leak, then there is grossly wrong something with the mask, or maybe your setting or something else. Then we should look for that and correct that.
Sure. And what about the IE ratio? What would make you go to the ventilator and change the IE ratio? What sort of factors would make you do that, Vijay?
I think most important will be the underlying disease condition. If the patient is, as we are discussing for last almost 1 hour or so, if patient is having COPD or airway disease, where we want expiration to be prolonged. So in those cases, we will keep IE ratio maybe at least 1:3, or 1:2.5 or more. So I think underlying disease is most important thing in deciding IE ratio.
Right. Any last comments from Milind? Milind, anything you wanted to add before I wrap up? Yes, please.
Thank you. Thank you for the opportunity. So the key thing is, NIV is not something you just switch on, you give the setting and walk away. It's a process. You have to, whatever prescription you have given, you have to start that and then stand next to the patient, look at their response, and then titrate it It's like, for example, for bronchoscopy, we don't say just we'll give, for example, midazolam and then that's it. Doesn't matter whether patient is sedated or not. We actually look at the response and then give a bit more if necessary. Or, similarly with ventilation, we have to stand next to the patient, see whatever we have set up. Is it enough? Is it too much? What's happening with the mask? And adjust it accordingly. So look at that. Get your mask setting right, because if you get your mask right and if you get your starting pressures right, the rest will follow.
Thank you very much. So thanks Milind, Vijay, Neerja. One chatting with you. I wish we had some more time. In the last couple of minutes, we'll have the poll questions. So Shivashish, if we can just push through the poll questions. The questions there'll be 30 seconds for you to answer the question, and then we'll have the answer. And there are, I think, a total of 5 questions, which I think have actually been made by Vijay. So I take no credit, nor should I be faulted if I don't know the answer like you guys, because I don't know what the questions are. But we'll have the questions. We want you to answer the questions. People who have completed all questions will get brownie points when we give out the certificates. So do answer the questions. And thanks to the panel, to the entire audience who've heard us today, the people who've sent the questions through, and to the Indian Chest Society for having arranged for this meeting, and for ResMed for having supported the entire module and being by our side in doing this meeting. So can we have the poll questions now, please, Shivashish?
The poll question is live. The first question is live, in fact.
Okay, so I don't need to do anything, Shivashish, correct? I can just sort of, the questions will be followed by the answers, or do I need to do anything?
Yeah, I'll just send you the answers and the first question which has been run in your chat.
So let's go through all the questions. Let's go through all the questions, and we'll just read out the answers thereafter, if that's okay.
Sure.
Thanks, guys. Thanks for doing those questions. I'll quickly run through the answers. I know there'll be people in the audience who are saying, these guys are late in starting and even later in finishing. So at that risk, I'll take 2 more minutes of your time. The first question was, EPAP helps in ensuring the following. And the answer to that is option A, which is improves FRC and oxygenation. The second question was, which is not a mandatory component of setting up NIV. And the answer to that is option C, which is dual limb circuit. The third question was auto-triggering is defined as, and there the answer is B, which is ventilator pressurization without inspiratory effort by the patient. Question 4, which is, which of the following is true? And the correct answer was all of the above. So TI refers to the time taken for inspiration or inspiratory time. Change in TI can lead to change in tidal volume. Adequate of TI and rise time is required to influence tidal volume. All those are correct. And then the last question, which was, which of the following is not an absolute contraindication of NIV? And that was, the correct answer was answer D, which is an unconscious patient. Not sure how true that is actually. The question has been set. So I guess you would hesitate twice, 3 times before putting it on a patient who's got a GCS of less than 8. But I guess it's not an absolute contraindication. And in circumstances where invasive mechanical ventilation is not mandated, for instance, as a preordained thing by the patient, you might think of it. So that's all for today from all of us. Please do join in again on the 6th, same time. And I hope to see you at that time. The Indian Chest Society hopes to see you at that time. Thanks, Neerja. Thanks, Vijay and Milind. Hope to see you. Good night, all of you. Bye-bye.
Thank you.